name is Morgan Schrader, and welcome to the Region 7 Zoomcast, where we conduct interviews with our Region 7 colleagues to learn the perils and pearls related to our COVID-19 responses in hopes of sharing lessons learned and learning something new that we can benefit from. Today, we are going to talk to Kate Tyner and Dr. Ashraf from the Nebraska ICAP and ASAP programs, how they are assisting long-term care facilities during the COVID-19 response. And so without further ado, please join me in welcoming Dr. Ashraf and Kate Tyner. Thank you two for joining me today.
Thank you.
It's a very casual day in the balmy Nebraska. So as we get our conversation started, let's learn a little bit about what Nebraska ICAP is and what is the ASAP program. And Dr. Ashraf, why don't you start off?
Okay, so Nebraska ICAP stands for Nebraska Infection Control Assessment and Promotion Program. This is a program that was established in 2015 and have been there since then. We have been, initially our task was to do infection control assessments in various healthcare facilities across the state and provide them guidance on how they can improve their infection prevention and control programs. So we started doing that, 2015 onwards, and all along the way, we started to do a lot more things beyond the assessments. We start to develop resources, tools, template, guidance for the facilities. We initiated training programs, certificate training programs. We initiated mentorship programs. So we have come a long way from just doing assessment and providing feedback. We actually have become an essential infection prevention and control resource for the state of Nebraska. And now when the COVID pandemic started, we recognize that the long-term care facilities were going to be quite vulnerable to this pandemic. So we focused our attention to the long-term care facilities, and so far, we have been working with every single facility that is having an outbreak in the state. Plus, now we are also starting to provide set teams up to provide help to hospitals and outpatient clinic and dental clinics if they need assistance with COVID-19 issues. So that's basically the ICAP program has been and how it has evolved. And then ASAP program is basically an extension of the ICAP program, and it stands for Antimicrobial Stewardship Assessment and Promotion Program, where we actually help healthcare facilities across the state, nursing home, outpatient, and acute care hospital in their antimicrobial, basically strengthening their antimicrobial stewardship activities, provide them help, guidance when they need us, and have done different projects with them to reduce C. difficile rate and decreasing antibiotic resistance.
Well, those sound amazing programs. So Kate, why ICAP and why ASAP? Why do you feel like the partnership is so invaluable now, and how, really, before you answer that question, how did you get to this point with your involvement in ICAP and ASAP? We all have a journey. So highlight some of your journey to get to this point.
Sure, good question. When I worked in the hospital infection control program, and then how that led into, then I worked in ambulatory infection control as kind of a contractor. At that time, working within the walls of your own institution, there's a lot of questions like, why do we do it this way? Or wouldn't it be great if somebody did this? And so, that felt like frustration at first, but then when when Ebola happened and money got freed up and the system really, nationally, they said, if we could do infection control really well, what would it look like? That's when Shelley and Dr. Rupp wrote grants to say, let's get some people involved and help the state health department to really see things, that we're seeing in these hospital walls. And so I got involved at that point, and really all those wishes that we had over time, like, could somebody help us look at this? For example, if there's a drug resistant organism, I know about it at my hospital, but the people at a very small hospital far away from me, they've never heard of it. And it's incumbent on me to call them and tell them what it is at least.
Right.
But now I'm also finding myself in the position that I have to educate them on that.
Right.
And so that was, on top of my work already. And then you think to yourself, why isn't there somebody who does this? And so I was thinking that, why isn't there somebody who does this? And that really led to me being interested in the program. And in addition, one of the best moments of my career, you're familiar with Dr. Phil Smith, Morgan. He was, the idea behind the biocontainment unit. Before the biocontainment unit, Dr. Phil Smith was famous for the Nebraska Infection Control Network. It was a group of volunteers, essentially, who came together twice a year to do a course on infection control. There was nothing like it in the country. It was for infection preventionists, run by infection preventionists. And the day that Dr. Phil Smith called me to invite me to become a faculty and a teacher in that course, I have goosebumps thinking about it now. That was one of the best days. I felt like I had made it, that somebody would want to hear from me on that.
Right.
And and so that coming on to the Nebraska Infection Control Network really, I think, put me on the track of why do I want to be involved with an ICAP-like program. And I think everything we were doing with the Nebraska Infection Control Network, I remember very specifically when Dr. Ashraf came to our program to kind of interview us, really. He was very talented. We really wanted him to come work with us, but he came to Omaha to see the ICAP program. And I remember talking to him. I had to go and meet him for breakfast and tea at 7 o'clock in the morning when he came into town. And I remember that's the first thing he asked me about is, he says, I have all these ideas for the Nebraska Infection Control Network. And I'm like, this guy gets it. This guy totally understands what we're doing in Nebraska and why we are people who could do a program like this. And so I really felt like then he had the vision for it. And I felt like a kindred spirit in the infection prevention world. And so that's what put me on the track to come here. And then ICAP was born.
There we go. So let's talk about relation-based medicines, because it seems to be that's what it is, right? ICAP is forming relationships with outside entities and feeling where we can support them in their needs and their gaps. Well, there's been a lot of support that is needed back and forth over the last 9 months, right? COVID opened a whole world to us. The COVID-19, the SARS-CoV-2 outbreak, however we want to word that. For both of you, and you guys can determine who goes first, let's talk about the relationship and the trust that is required by institutions to contact you at ICAP to ask those questions. And where do you feel some of the gaps are coming from?
So let me start first, and then Kate, I'll let you chime in, because I think so when we're talking about relationship, one of the things that we didn't talk about, or we should have talked about right from the beginning, is to give the credit to Nebraska DHHS, the state health department, the healthcare associated infection program that had the vision, to form this kind of partnership, because the very first partnership that made it happen was the state vision to reach out to an academic partner and say that, we can have funding to do that, but instead of us trying to hire a couple of experts to run this kind of program on the state level, why don't we just partner so that we have access to a group of experts that we can then expand on and build, and that is going to tie into what we're going to talk about on how we build the relationship and what helps us in building that relationship. Is partnering with the UNMC and Nebraska Medicine that already have recognition in the state to be the subject matter experts on infection prevention and control because of the work that we have done in the past. With the biocontainment unit and others, that was the first pillar that made us, develop the relationship with the rest of the facilities. And I'll let Kate talk about that and that how it helped us, and it helped the state too in that manner.
Right.
in getting the objectives that they were looking for.
Right. And so, Kate, before you start, I do focus a little bit on that relationship. I know you and I early on in COVID response worked with DHHS on a pool of resources. So kind of highlighting that in the conversation as well. And Dr. Ashraf, I think you worked on Dr. Kelly, everybody. It was a very group effort on that. So try to make sure that we incorporate that in as well, Kate.
Sure. So I would say, kind of building off, the state had this vision for how we could offer the help. I would say when I came to the team, I'm no better infection control person necessarily than the next person who has 15 years of experience. You know, you learn that craft over time, you learn the expertise, you learn the guidelines, et cetera. What I felt like I brought to the group that was different, before I was a nurse, I worked in essentially customer service. I worked at a golf course for 9 years. That's where I learned that kind of customer focus. And so when you come to the point where we have this thing we can do with facilities, are we going to get them by hook or are we going to get them by crook? You know what I mean? And so I think there's a certain amount of, in the industry, people who think, well, if you're the state health department, you just tell people they have to do it. They just have to do it. They have to join your initiative or else. Right. And we've never really approached it that way. Our approach has always been, if we offer an exceptional product, people will want to work with us. If we show them that we are the most helpful, the most kind of hospital or long-term care focused group, we're out for their best interest, they will come. And I think that's been a guiding force throughout. And so when it comes to creating resources and whatnot, I very much feel like we have very good tools that we have built over time. The tools not only are things we create, but when I help somebody answer a question, maybe there's 4 resources I could send them to. I'm going to send you to the one that I think is the best. I'm going to send you to the NETEC specimen collection site because it has an infographic, it has a video, and it has some competency development forms. And so over time, you learn those things, right? And so the example you're talking about was when, at the beginning of the pandemic, when the state health department was really trying to come up with a resources page. That could be a list of 89 links and nobody could find anything, or it could be conceptually, you know, kind of categories of things. And where ICAP fit in was, you know, we have the category of things that are long-term care specific, was we had a lot to offer, but we also had this experience of this looking for our favorite resources on things. And we could say, you know, we think this one's the best, it's tried and true, put that link on your website. And so, again, we're acting in people's best interest. I'm not trying to advertise for 4 entities. I'm saying, I want you to have the best tool in your hands. I'm going to put up that tool. And so, you know, when you come to the ICAP website or the DHHS programmatic links, some IPs who have experience have said, we think this one will get you the most bang for your buck.
Right. So it's more like a salad bar style approach. You only see really good items towards the front of the salad bar, the secondary options, and you know, someplace else, right?
Exactly.
Okay, I like it. I like it. So as we've kind of been in this now for 9 months, where are you seeing some of the challenges broadly across the state, you know, outside of maybe our setting here in Omaha? Where do you think some of the challenges are in Western and the Panhandle and all of those areas? What are some of the successes that we don't actually highlight all the time that are happening out there in Nebraska across the board? And we'll kind of go from there.
Let me say first the success. I think I say once a day to a long-term care facility that I'm working with is, where will you be safer than in a long-term care facility? And I feel like NETEC, ICAP, DHHS, we have engineered that response. We have been working with them so consistently and so long. We've provided PPE, we've provided testing methodology. When somebody comes to me and says, I'm afraid to go to work, I say, there is no place that you will be safer, because we're testing the people in this environment very aggressively. We have all the PPE you could need. We can coach you up on the techniques. Where would you be safer? And I'm very proud that I can say that now, is we can get you there. I think that's a success. It's really easy to say that long-term care continues to be a huge challenge, because it's my sense that we have no control in the rest of the world. And so the outlet is people going to work or going to visit a long-term care place, and it's going to be the spread of COVID, the mortality and the morbidity of COVID is only going to be amplified in that setting. So all the failures we're seeing everywhere else are simply amplified in that environment. And it's very hard for us to continue to control that when there's no control outside of those halls.
Okay. Dr. Ashraf, how do you think we combat that? I'm not going to disagree with Kate, right? That facilities themselves are structured in a way that everything that is going to happen in that situation, right? They have been isolated for the individuals in that facility have been isolated for a long time, especially when you hear that healthcare workers are the ones that are bringing it in. We've all heard this. This is something that we've been faced with. What is the push that we can give these facilities to keep on keeping on and doing the best possible? What is some positive response that we can give them?
So let's start with another positive point. I think Kate mentioned one positive point. Let me mention another positive point. Nebraska, at least when I last checked, Nebraska was among the top 15 states that have the lowest case per 100,000 population for COVID-19 in nursing homes. We have the, again, top 15 state in terms of the lowest deaths, per 100,000 population in the nursing homes. Even though we still think there's a lot to do and lot to achieve, I think we have so far been able to put the plans in place, and I will congratulate our nursing homes that are working day and hard, the staff there that are kind of putting every single effort that they can to make it that way. Okay. So I will put that on them. Yes, we are providing them guidance, we are providing them support, but they are the one executing it. So I think they have done so far great. The question is that can we keep it up? Right. Can we keep it up, and how to combat that? That was your question. Is like what can we do to because now we're seeing the community cases on the rise. Right. How do we continue to keep our nursing homes safe? One of the things that I have been speaking when I've been speaking with the nursing home infection preventionists and other leaders, I'm saying to them to continue to send the message to the frontline providers that you are taking all the precautions when you are working in the nursing home. You're wearing a mask, you're wearing, doing the hand hygiene, you're keeping your social distancing while you're working. Don't leave that alone when you go out in your practical life. Continue to take the same precautionary measures that you are taking while you are at work when you go out. We have to keep educating them, keep reminding them. We are all humans, and we get fatigued, and we can lose sight of the big picture. And the nursing homes, by educating, by reminding their staff members, I think can play a very important role. They can stress the point that all these residents in the nursing homes are actually dependent on their care, and they are banking on us doing the right things. And I think that is the strong message that if they can get out, can make a difference. They cannot control the entire community, but they can try to talk to their own healthcare providers who are working in their facility, and then the visitors also, educating them on why we are doing what we are doing, because there are people, family members out there that are getting frustrated about the measures that have been taken in the nursing homes. but just showing them about, just show them the data. We are doing much better because we are taking all these measures. And then getting that message across, I think it will make a difference. And I think that's what we need to continue to do. Plus, all the other measures that we have been advocating for anyhow, screening, testing, hand hygiene compliance, PPE compliance, all of those things.
So I think it's interesting that you say that there's almost like a call to arms for the workers in these facilities, hospital, long-term care facilities, clinics, because we are getting extra education in terms of IPC, infection control practices, and how that relates. I like the fact that we're engaging staff members outside of the facility to carry on with the recommendations that are put forth to wear your mask, perform hand hygiene, limit gatherings, and things like that. Well, not just at work, but out in the community, and kind of leverage their knowledge to educate others as to what's going on. What do you think the biggest challenge currently is for long-term care facilities outside of IPC as it relates to that document that came out in September? Remember, the return to opening and how that gauged entrances. That is a challenging document to read, even for us that work in infection control practices. If this, then that. If this. How do you answer some of those questions as to what makes logical steps? What are the 3 things that we can do to ready ourselves to deploy that document's guidelines? How would you answer that?
I can tell you what I've been telling people, Morgan, is what really spoke to me in that document for a number of reasons is the compassionate care visits.
Agreed.
They expanded what we would call a visit for compassion. And I think that really rings true with everybody's heart, is we need to do that. And what I've been telling facilities is, think about the people who meet that definition and begin to prioritize around who you think meets that. And can you do some visits? Can you do some visits that meet that need? And that way we're working on behalf of our heart. We're addressing those residents who really need that to survive. Literally, they need to see their family to survive. We need to address that. And I feel like if we start there, I think the challenge is if these facilities, they don't have extra people who have been hired to meet, managing PPE inventory, teaching how to do PPE, auditing, testing. They don't have more staff to do that. So they're already working with they're doing more with less. And so I tell them, okay, how many could you do? How many compassionate care visits could you prioritize? Let's talk about how to make that happen. And I feel like that helps them meet the spirit of that document and tiptoe in to visitation without floodgate opening.
So Kate, I like how you answered that. Dr. Ashraf, I'd like you to kind of chime in on this. Have you seen nursing care facilities take advantage of the waivers and engaging people that maybe have not been at the bedside for a decent amount of time to receive the training to help relieve some of that for truly trained individuals to help coordinate the compassionate care visits? Like, are we seeing that resurgence of people that maybe now are office mindset staff to engage back into the patient care realm?
People have used the administrative staff, a nursing home have used administrative staff to provide the patient care, but not to relieve anyone. Because they are short. So there, to be, in all honesty, there is no relieving right now the situation. Just recently, when I last checked, 25% of all nursing homes and assisted living facilities in the state were having an outbreak in our state right now, and that's when we are saying that we have been doing good so far, correct?
Right.
That's when we have been saying that I do actually think sometimes that what is happening in other states, if we are doing good with numbers with this, but in the reality is that 25% of the facilities were having outbreak. Now, I think where we have done the most benefit, or where we were able to be successful with our facilities, is to contain when it happens. So when I say having an outbreak, it can be a single case in a staff member or a single case in a resident, you know. I think even though we are having outbreak in 25% of all our facilities in the state, we have been, for most part, have been successful to contain it very small and get over with it real fast. And I think that's where our success have been. However, in order to contain that outbreak, there have been so much measures that have to be taken place that it stresses out the staffing capacity of the nursing home. You know, just think about this. You have a couple of staff positive, and they have worked, in a few different units in the facilities in the last few days before they become positive. Then we are starting to cohort those people because they're in quarantine now. Now, some of them becomes positive, then we have to put them in a COVID unit or a red zone, we call it. And then there might be one or two areas of the facility that may not have been touched with this outbreak. So they are in a green kind of zone. But for the facility now, they have to now start thinking about, when they're thinking cohorting, they are thinking now 3 times probably the level of staffing that they need before that outbreak start. Because they probably want to cohort the people who are working in the COVID unit. They don't want them to come, back and forth from the COVID unit to the other place. And then the staff that is working with the exposed residents, they're trying to protect the green space, green zone from that. And so they're trying to cohort the yellow zone staff in yellow zone and green zone staff in green zone. All of a sudden, they're kind of tripling the capacity of people that require some time. In some cases, not in all cases, but in some cases, can be double or triple the amount of staff that they are looking into. So yes, most of the time they are able to contain it, but it requires a massive amount of PPE resources, massive amount of staffing resources, and massive timing from administrative staff in doing that. Staffing to do testing.
Right, that's what I was going to add realistically. And then the days where every one of the patients or residents and every one of the staff are going to get tested, that's twice a week. And now we're vaccinating for flu, staff and residents too. So that just the volume of stuff they're getting done is enormous, but we have to understand there's some stuff that's going to start slipping.
Agreed. How do we help them or partner with them so that there isn't that slippage? I mean, coming from my background, right, I can efficiently come up with a plan that runs extremely lean. But it's not always applicable when we go out into different care facilities with the memory care units in the, more, a little bit not as assisted living, but more requiring, more of the skilled nursing levels. Do you have any tricks of the trade, Kate and Dr. Ashraf, that they can use to deploy that? Like, what is reasonable? If you had a facility, let's say, of 100 people and it's testing day, and that's 100 residents with, I'm going to say 30 staff, so 130 staff plus flu vaccines. Do you have a way of which that some really honed in aspects that they can utilize to deploy something that's reasonable in that 8-hour or 10-hour day shift to get all of those requirements done?
I've only learned from the facilities I'm working with. And so I like to share, best practices. And that is, CMS has defined the counties who are testing twice a week. So we know where that's going on, and they essentially are planning for that. And so what seems to be working well for facilities is if they do their staff testing on Mondays and Thursdays or Tuesdays and Fridays, and then they would capture residents at least once in that week in between. How they're capturing influenza vaccination now, it sounds like they are, as vaccine becomes available, they're just putting that into their usual medication administration processes. So they would have so many vaccine doses, we're just gonna give it on med rounds today. And that's what they say. And I take no credit for that. I'm sharing what I've heard from other people that's working for them.
Awesome, but that's how we learn, right? And
that's where we feel our job is on these webinars, is when we hear good things that are happening, like, let's amplify that. Let's push it out to the group. Even small things if it's working for you, please tell us those things so that we can push it out to the larger group. That's what makes it feel like a community, and it feels like we're working together even though we're socially distanced and all those things.
Right, which we are all right now. We're in 3 different spots, right? Some of us have really awesome scenery, Kate, and Dr. Ashraf and I have walls, right? And we don't have the, but we're not saying anything. So Dr. Ashraf, what do you have to build upon Kate's best practices that are heard from around our local communities? What is your call to arms, kind of given all of the challenges that we currently have with trying to do compassionate care visits on top of 2 times a week testing, on top of influenza vaccine, on top of all of the ADLs and partnerships that we have, and care requirements that we have to do. What is your takeaways?
Yeah, I think one of the aspects that facilities also have to do is to staff the visitation, correct? So yeah, we talk about testing, we talk about all of that, but we also have to start looking into, the resources that are spent on visitation. If the facility is going to have unlimited number of visitors coming and entering the facility, you're going to have a hard time for the staff to keep an eye on everyone and make sure that that they are following the protocols that needs to be followed in terms of hand hygiene and mask wearing and all those kind of things that they have to do. I think one of the best practices that have been implemented for that purpose is to try to schedule those visitation instead of just having an open visitation where somebody can come in. Yes, the CMS have allowed visitation, but it doesn't mean for those counties that have less than 10% positivity rates, basically what we call yellow and green counties, inpatient visitations are, in-house visitations are allowed. But then I think what the facilities can do and are doing, some of them, is to scheduling them so that they can see what their staffing levels are, and they can have that many staff available to monitor their visits and make sure that they are following the guidance that they are following. Some of them are actually developing a cheat sheet for the visitor. Basically, there's something that they will get in as they enter the building, where it says, as a visitor in this time, what you need to do. The mask on all the time. Don't roam around in the facility. Go to the designated area and be there. Do the hand hygiene frequently and things to that effect that they are going to have those kind of forms kind of develop and hand over to the visitors when they enter the building. It's basically part of their education, visitor education. So that those are some of the things that the nursing homes can do, is to organize and see their resources, what the resources are, and try to bring try to organize things in advance based on those resources. One other thing that we have kind of discussed with the long-term care facilities is to anticipate what is about to happen. Now, you can never anticipate 100%, but I think it's it's a good guess right now that my facility may have an outbreak. If you're guessing that's probably the good guess, because it's very hard not to have an outbreak. When the outbreak definition is one person becoming positive, correct?
Right.
In the facility, or at least that's a trigger to start looking for an outbreak. So anticipating that and having a space in the facility already designated to move people around, move residents around in that area and make this a COVID unit or a red zone in your facility. So that kind of another thing, and it saves time. If you do it that way, if you already have a space in there, you can transition very quickly to a containment response. But if you don't have a space already in place, then it takes time for the to go into that full containment mode, because you're already trying to figure out how I'm going to make this a space where I'm going to put the partition in. How can I move somebody from this unit to that unit, without contaminating the other unit? And all of those things start to kind of come in at that point of time, and you get into a panic mode. So, which again, use more resources then that is probably not needed to be diverted at that point of time. So I think that's basically what I will add to Kate's point in terms of organizational thing that you can do to avoid the crisis.
Right. So I'm going to address kind of an elephant in the room while we're talking about getting ready and planning for visits and compassionate care visits and all of that. We are quickly approaching the holiday season, of which we're 30 days out. For families who really going to have this longing of, I hear you, Kate, you're deep breathing already on me on this, but you have to, we can see the compassionate side of this from families who really have been vigilant and staying the course with COVID response and not bombarding the long-term care facilities or nursing, skilled nursing facilities on not seeing their loved ones. But now we're really coming to that period of which the holidays bring back all of those emotions, and families are going to want to. So I hear what you're saying, Dr. Ashraf, that facilities should start creating a plan now, right? Plan for your outbreaks, plan for those challenges. But what guidance can we have in terms of, are we going to allow families to drop food off? How are we going to get it through these different zones? Can we schedule those visit times? What is reasonable request? Knowing everything that we know and all of the challenges that come from meeting those compassionate care visits, from meeting the regulations that are put out by outbreak standards, CMS regulations. So let's spend 5 minutes or so and talk about that. Kate, I'll let you start on how are we going to meet all of those needs, check all of those boxes from families and to residents and beyond.
So I want to start with, maybe let's create some buckets. Right. Michael Osterholm from Minnesota did a really good interview last week, and I felt like he hit the point, just exactly the words that needed to be said. There are some residents, not all, there are some residents where we need to talk to the family and we need to talk to the residents and say, this is your COVID year. This is the year where if you want to have Christmas next year, we just have to not do it. We have to have a remote visit. We can't let you go. There will be some people who meet that category. My own family is that way. This is our COVID year. We're going to have to skip it this year. Okay. And so I think that's the first bucket, is the people who we can reasonably say, you will live to see another Christmas. Let's keep you healthy enough to get there. Okay. That was kind of Michael Osterholm's world. It was a great interview. I think the other bucket is people who may not meet that. And so those people, again, can we prioritize those people who, can we list out the people who will remember that they had a visit and won't be able to leave the facility, and kind of bucket those people. Can we as a facility say, what can we reasonably do? How much PPE do we have? How much staff do we have? And can we start scheduling this out and just start from a place of reason? Okay. And I think for some residents who have dementia, if they won't remember the visit, do they go down farther on the list? Is that a reasonable approach, or is it not? I think those are good questions that we can kind of start sorting residents out. I think if we look at it as, all 400 facilities in Nebraska and all the residents who live there, it's impossible. But if we start bucketing it and try to address categories, maybe we'll come to some reasonable solutions. Okay. From a PPE perspective, Dr. Ashraf, what do you think about gray zone for people who leave the facility for a home visit?
Yeah, so, you just mentioned gray zone. I don't know how many people outside Nebraska actually will recognize the term gray zone. The term was actually kind of a invention.
It was Dr. Ashraf's invention, yes.
Okay, there we go.
Because we have this red, yellow, and green, and we're trying to come up with some color, and I don't know why we chose gray, but it was basically meant to identify an observation area where when a facility is not having an outbreak and is admitting someone who definitely don't have an exposure that we know of, but definitely had some high risk activities that they have involved with, so it's not naturally meeting the quarantine definition or a yellow zone definition, but because of the high risk activities that they have been in, meaning going on, a restaurant or something like that, you may kind of put in an observation area for 14 days and still have quarantine just because of the setting. The nursing home setting is so, we didn't want to take any chances. So that is what we call transition zone or a gray zone, basically. So you transition into the facility through that unit and then come into the facility. So that's what Kate is referring to is the gray zone or a transition zone for those people who go out in the community, and community is having high rate of transmission. Now we don't know that they came across with anybody who is positive, but they may have. And do we quarantine them? And I think there is an ongoing discussion going on between the state health department, our nursing home associations who represent a large number of nursing home and assisted living facilities in the state, and ICAP team right now in coming up with these parameters on what can be reasonably put in place that we can do some visits and not completely have no visit at all, or we can have some people actually go outside to their family for either a few hours or a few days and then come back. And yes, they may have to quarantine for 14 days in a transition area or a gray zone that we call, but it's probably worth it to spend a few days with the family, even though they may have to quarantine a little after that. I think our plan is to come up with guidance that we can then share with all our nursing homes and assisted living facilities before the holidays.
Okay, I think those are some reasonable, bucket style delineation as to how we can safely do that. Let's talk about decorations and the ability to clean and disinfect while we're in this holiday, right? In my mind, I'm like Christmas trees and lights and light bulbs.
I hadn't thought about it. That's a truly fresh question, Morgan.
It is a truly fresh question. As well, with Thanksgiving around the corner, you'll have the turkeys up, and then we're going to take the turkeys down. Christmas. Would we agree that currently in the current needs to cleaning and disinfect, less is more for the holiday light festivities, or are we supporting full bore garland and lights down on, door decorations in every zone, red, yellow, green, gray?
Right.
What are your thoughts on that?
So I think the point you're making pretty eloquently, Morgan, is high-touch surfaces. We should avoid putting things on high-touch surfaces. That's a very fair, reasonable suggestion, is things like overbed tables or things that residents would touch a lot. I wouldn't wrap garland around a handrail in the hallway because it would prohibit me from cleaning it. So I think that's a reasonable place to start, is where should we avoid decorating so that we can continue to disinfect a surface regularly. I think we got to credit the long-term care facilities. They know how to do some of this. They're not immune to norovirus or influenza outbreaks. And so I think that they know what they have to do for high-touch surface cleaning and things like that in, the winter respiratory virus season, similar to visitation. They're used to this. So I would say that would be the first thing, is avoid high-touch surfaces. They also are really rigorous about fire code, maybe even more rigorous than some offices and things like that. Things have to be fire retardant and all those things. I don't know. What do you think? Garlands and trees, Dr. Ashraf? If nobody's touching them,
yes,
are they a fomite?
No, I think if the decorations are set in a way that is not going to be something that everybody comes and kind of touch and see and feel, I think we probably should be fine with that. They need to have something, correct, to feel like we are in the holiday season, correct. So no, I think we have to be careful, but we have to be reasonable too.
And I'm thinking, like, say you wanted to do a craft and create an ornament or a decoration or something like that, something engaging for the residents. We're not doing communal activities in most areas now because of our rates of COVID in the community. You could think about kits and things like that have individual amount of supplies that a resident could do with a little bit of guidance or at the elbow support in their own room. And then that thing that they make becomes their own. They get to keep it, but maybe they don't give it to someone else, or maybe they give it to only their own family. Something like that.
Meeting that need for tactile and engagement and creativity, as long with keeping our standard IPC practices. I think this is a great example.
Right.
Well, fantastic. Well, as we are wrapping up this conversation and talk, what are some last key messages, Dr. Ashraf, I'll let you start, as we continue to engage long-term care facilities in a variety of care settings across Nebraska? We are 9 months into this. What are your key takeaways, like 3 points that you want people really to know and to keep that charge going as we move forward?
Plan. The number one thing is plan. Anticipate, plan, and then execute.
Okay.
We, as you said, Morgan, it has been a long time. It has been a long time, and we know that a majority of our nursing homes majority of our long-term care facilities have already experienced a case of COVID-19 in the facility. There's still some that have not, but a majority of them has already experienced COVID-19 within their facilities. Some have larger outbreaks, some have small, short, the very contained outbreaks. They know what they have to do. They have to anticipate as we go into the winter more, and as we go into the holidays, and they have to anticipate this can happen. They will prepare everything to prevent it. They have to, but then anticipate that this happen. Put a plan in place. Now, 6 months ago, when we were talking to the facilities and they didn't have a plan, it was understandable. But I think at this point of time, there's a lot of resources out there. Nebraska ICAP has many resources on our website. We're doing weekly webinars. We are available with office hours. You need something in planning, you are not sure about something, you can call an office hour and get that answer if you're not sure. So once anticipate and then put a plan in, plan for prevention before the outbreak happen, and plan to contain the outbreak when it happens, both in place, so you're not scrambling at the time. And then, when an outbreak happen, you have the plan already ready, execute it. Execute it according to the plan. There will be challenges and the plan will change a little. That happens all the time, but that's why ICAP team is there. We're not leaving anyone behind. We are helping them out. Now, what it does is that if facilities are better prepared, have a plan in place, already thinking through the things, what it does is it helps ICAP be a little quicker in terms of providing that assistance that they need. We don't have to then spend a couple of hours. We can spend 15 minutes and can be as effective as we will be in a couple of hours if facility is not already had some planning in place. What it does, then save us time to help some other facilities out there. And as the numbers are increasing, we are already thinking, we are planning that our numbers are going to be increasing in terms of the facilities needing our help. If we share that responsibility, the nursing homes, the assisted living facilities, if they share some of the responsibility of this preparation along with us, we can make a good team, and we can continue to fight through this storm, and this and come out on the other end, relatively fine. There will be. That's the nature of this, is that if you get an outbreak in your facility, the outcomes may be very. We have seen facilities losing many residents, and that's heartbreaking. We know that we cannot completely avoid that, because it's just what the nature is of this outbreak, but we can reduce the morbidity and the mortality aspect of this pandemic by better planning and better organizing. And I think that's what we are focusing on. That's what we want to do, and that's what the ICAP team is there to help.
So we have a new PPE charge by you. Plan, evaluate, and execute. PEE. P. So, Kate, now where are you
Like
at? What are your
I can't add to that. That's awesome. I would say
we have PPE and we have PEE. Right?
PEE,
There we go.
yes. I would let Dr. Ashraf's key takeaways roll. He's absolutely right with that. I would maybe put in a plug for the staff that are working in long-term care. All they see on the news is how so many people are dying and so many people are sick in long-term care. We don't see the accolades for the heroes working in long-term care the way we see our hospital frontline and maybe our EMS frontline folks. And the people who are working in long-term care, just capable and consistently deliver on these heroic measures, all the things that they've been asked to do, things that I would have never anticipated as a bedside nurse. You have people who literally pull up their camper outside of a long-term care facility so that they can be there to support. And just people day after day who come to work, and, they're not getting the thanks that a lot of the other healthcare workers are getting. And they will emerge from this as the heroes. And I hope that they will be recognized in the future as the people. They are kind of like the last bastion of, help at the end. Everything that we've failed along the way that made it to the long-term care, these are the watchmen on the wall. And they're really delivering at that very front place. And I hope that we can recognize them in the future, and that it maybe brings more people to work in that environment, because it's a place where they need expertise. It's a place where their expertise, does volumes to help the people that they care for. So I would say that's been my key takeaway with the pandemic so far, is just, I think, the heroics that are happening there.
Well, and we have the opportunity right now to applaud their heroic efforts, right? With three of us on this call. Dr. Ashraf, you have something to add?
Yeah, I definitely do. What breaks my heart sometimes is when I hear the news, when I see the news, and there's some mention of a long-term care facility that have an outbreak, and sometimes the portrayal can become like it might come out. It may not be the intention, but it might come out as the facility is really bad, and the people working in the facility didn't take care of anybody, and they didn't take care of anything, and how the COVID spread, and everybody got the COVID, and so many people have died, and it starts to look like that the nursing homes are doing some terrible things in there. And our observations are that it is not exactly true some of the times. We have seen facilities avoid outbreaks for 3, 4, 5 months with 0 cases, and all of a sudden, widespread outbreak in the nursing home. Same people, same work, same everything, but it happened. It happened. That's the nature of disease. They can asymptomatically spread within the facility, and before you know it, it has gone over. You know, there might be somebody make some mistake, but somebody makes some mistake every day, everywhere. Even in the hospitals, even in the outpatient clinic, somebody makes some mistakes everywhere. No, that's why we continue to strive to get better every single day. But it is not about, I think how we shouldn't see it is that, how we should see it is that what is causing them, what is leading them to have an outbreak? What is that factor that leading them have outbreak? And it will come down when people will start thinking about it. It will come to them that usually we are seeing outbreaks, and for the most part, the outbreaks happen when the cases start to go up in the community. It didn't happen just in the nursing home. It's happening in the community, and it's going into the nursing home and causing an outbreak there, which sometimes is really beyond the control of the nursing home staff, because they just didn't even figure it out that somebody was asymptomatically spreading the infection. So then when we think about it that way, we start to think then, oh, maybe it's our responsibility too, to prevent the outbreak in that nursing home, because I'm part of this community. If I take all the precaution, if my friends take all the precaution, if my community take all the precaution, and if we would have avoided the case as a community, maybe the outbreak would not have happened in the nursing, And I think that's where we need to see. And as I said, all those things can come onto the news and becomes the news of the day. But there are many other facilities, many other nursing homes that are able to contain the outbreak very, very effectively when it happens, and did a magnificent job on keeping the number of cases down. We never see any appreciation coming out for them that, this facility have 2 staff cases or 3 staff cases and ended out without having any resident case, correct?
Right.
You don't hear those success stories that are happening every single day.
Yeah.
Well, good. So it goes back to the call to arms of I wear my mask for you, right? Community-based.
Definitely.
Right.
Well, we hope all of our listeners found some value in our conversation today. I truly enjoyed the conversation with you, Dr. Ashraf and Kate. It was your time and your dedication to this is very much appreciated. We very much appreciate you taking an hour out of your day to have this chat. Thank you, and thank you to all our listeners for listening in. If you have any topics that you'd like to learn more about, please send your ideas to nbu@nebraskamed.com, and we look forward to visiting with you on a future Zoom chat. So have a wonderful day. Thanks, guys.
Thanks, Morgan.
Thank you very much.
Thank you.